So thank you. Good morning, chairpersons and dear friends. And this is a case on bilateral pigment epithelial detachments and right central serous chorioretinopathy in a COVID patient. No financial interest to declare. We hereby report a case of pachychoroid spectrum disorder in a patient of COVID and discuss its possible etiology. The patient was a 30-year-old male from Patna, railway official, hospitalized with RT-PCR proven clinically moderate COVID-19 pneumonia. He presented with shortness of breath and fever for 5 days at the time of admission. On the 6th day, he developed acute blurring of vision and color desaturation in the right eye, not associated with pain, distortion of images, or flashes of light. The patient was not a known case of systemic diseases. There were no previous ocular complaints, and there was no history of medication. The family, social, and occupational history were unremarkable, except for a positive travel history 15 days ago. He was being treated while admitted to our COVID ward according to the protocol, and the tablet dexamethasone 6 milligram per oral once daily was started 1 day ago. On examination, the patient was a mild case of COVID with saturation of oxygen 96% and bilateral basal crepts. A bedside examination in the COVID ward showed visual acuity of at least 6 meters and a normal anterior segment examination. The ocular examination at the bedside, the fundus, showed a right central serous chorioretinopathy and bilateral pigment epithelial detachments. So the patient was diagnosed as both eyes pigment epithelial detachment and right central serous chorioretinopathy with mild COVID-19 pneumonia. The differential diagnosis were rather unlikely. He was managed with withdrawal of the oral dexamethasone 6 milligrams started the previous day in consultation with the physician in charge, and was put on observation and counseled about his condition. The patient was discharged when stable as per protocol after 2 days with recommended follow-up at 3 weeks. However, he reported to us at 5 weeks. At this time, in our OPD, the visual acuity in the right eye was 6/9. The PEDs were as before, but the central serous retinopathy, the serous detachment in the right eye had enlarged. The OCT macula corroborated our findings, and the neurosensory detachment was seen with the exudative material. Choroidal pachyvessels were noticed beneath the neurosensory detachment. This is the left eye OCT. Assessment in the post-COVID OPD using DAS-21 questionnaire revealed a score of 14 corresponding to moderate anxiety. Observation with counseling by a psychologist led to resolution of his condition at 6 weeks follow-up. Further follow-up could not be obtained due to the ongoing pandemic. The presumed pathogenesis of CSCR is choroidal ischemia and increased capillary permeability. There are only a few incidents of PCSD in patients admitted in hospitals for COVID reported in literature. Acute CSCR may have been precipitated by corticosteroids, but only 1 dose of dexamethasone was given. So the role of endogenous steroids, the stress of hospitalization, in addition to the psychological burden, cannot be ruled out. It is possible that the development of pachyvessels was due to choroidal ischemia, which is similar to the study of Savastano et al. In the peripapillary capillary plexus. Hence, this is a case of pachychoroid spectrum disorder. Personality assessment and counseling may be included as part of COVID care to mitigate the risk of visual complications. The alteration in choroidal perfusion due to COVID-19 may contribute to the development of pachyvessels, underlying the pathogenesis of CSCR in these cases, which is an area of further research.